This computer. Assalamualaikum, a very good morning. So I'm Dr. Wan Ashraf Zaidi, and today Dr. Siti Nazifah will be presenting her topic that she put, and yeah, obviously with my advice, and hopefully we have good interactive Q&A afterwards, so because a very brief one. So let's start then, Nazifah.
Okay, Assalamualaikum and a very good morning. I'm Siti Nazifah, first year master student. My supervisor is Dr. Wan Ashraf. Okay, today my topic is high neuro. Should I give 1 or 2? Okay, I will start with the case discussion. He is Mr. M, 67 years old, Malay man, underlying diabetes mellitus, hypertension, dyslipidemia, but not on proper follow-up. Came in due to dysarthria a day prior to presentation. However, there is no body weakness, no blurring of vision, no facial asymmetrical, and not complaint of having headache. On examination in the from the ED side, GCS is full, was full, BP 200/90 with a pulse rate 84. How about the sugar control? Is actually normal, DXT8. Lungs clear, CVS S1 S2 no murmur. No cranial nerve abnormality was detected, but there is a significant moderate of dysarthria. As for the neurological examination, for the right and also the left side of the body shows that normal. It's just a reduced sensation over the glove and stocking distribution only. Okay, this is a CT brain. Was carried out on the day of the arrival to the ED itself. Okay, there is a hypodense area over the internal capsule here, and then for the CTA, there is well opacified with no thrombosis over the vessel. For the diagnosis is actually this patient having a lacuna stroke with NIHSS 2/42. Okay, this is the first case. As for the second case, this is Madam M, 65 years old lady, underlying diabetes mellitus and also hypertension. Came into ED with left hemiparesis and also numbness. It started around 6 p.m. But it's lasted for about 6 hours prior to presentation to the ED. However, no other symptoms. On examination, the GCS full, BP is about 140/70, pulse rate 70, SpO2 is about 99% under room air. The XT doesn't show any hypo readings, just 7. Neurological examination also normal. The CT and CTA brain also normal. Okay, as for diagnosis, she's having transient ischemic attack with a ABCD score 7. Okay, now we move on to the question. Okay, what is the recommended antiplatelet for the secondary stroke prevention in a mild stroke or high-risk TIA?
Can you see the poll coming?
No, actually, no, I can't see.
Can't see, oh yeah.
This is a multiple choice question.
Poll coming in?
Yeah.
Okay.
You can start answering these 2 questions.
We have 52 participants, including us, 54. So Let's wait for them to answer first. So we have, and the poll as 60% participants already answered. Okay. And poll and share the results. Can you see the results?
Okay.
Okay.
68% choose clopidogrel and aspirin. For the second question,
You can see 73% choose 21 days and 20% choose 90 days. That would be interesting, right?
okay.
Okay. Continue, Nazifah.
Okay. Now I move on. Cannot move. All right. Okay. All right. It's about more than half actually choose clopidogrel and also aspirin. Okay, now I'm presenting more towards the clinical trial. Okay, there is a clinical trial, what we call that match. It's actually published in July 2004. This is the randomized double-blind placebo-controlled trial to compare between aspirin 75 milligram per day with a placebo in a 7,599 high-risk patient with a recent ischemic stroke or transient ischemic attack. So the duration of the treatment and follow-up up to 18 months for this trial. So the primary endpoint is actually they will develop a recurrent stroke, MI, or the vascular death. Okay, for the primary endpoint is actually much more higher for those in the placebo and clopidogrel group. But then the absolute risk reduction for the aspirin and clopidogrel is actually just 1%. So in a conclusion, actually the adding aspirin to the clopidogrel group is in a high-risk patient with a recent ischemic stroke or transient ischemic attack is associated with a non-significant difference in reducing the major vascular event. However, the risk of the life-threatening or major bleeding is increased by the addition of the aspirin. And then for the CHANCE trial, published in July 2013, this is also the randomized double-blind placebo-controlled trial in which it had been conducted in 114 centers in China. This study is actually randomly assigned 5,170 patients within 24 hours after onset of the minor ischemic stroke or high-risk TIA to the combination therapy with the clopidogrel and also aspirin. So as you can see from here, there's a group 1, clopidogrel started day 1 300 milligram, and then subsequent day is 75 milligram plus the aspirin 300, and then 75 milligram for 21 days. So this trial actually had been conducted for 90 days. Okay, so as for the what we call that the result for this trial, for the ischemic or hemorrhagic stroke, it's much more lower in the group who had been received clopidogrel and aspirin compared to those in the group which received placebo and also aspirin only. So the percentage is about 8.2% compared to 11.7%. However, the moderate or severe hemorrhage is not increased actually compared with these two groups. Okay, for the next clinical trial point, this is also the randomized trial in which the 4,881 patients with a minor stroke or high-risk TIA were enrolled at the 269 international sites. they assign patient with a minor ischemic stroke or high-risk TIA to receive either clopidogrel at the loading dose 600 milligram on day 1, then 75 milligram per day plus aspirin at a dose 50 to 325 milligram per day. So as a result, for the major ischemic event, it's just what we call that 5% for those in the group 1 who had been received clopidogrel and also aspirin, compared to the placebo plus aspirin is about 6.5%. So for those who had been received a combination of the clopidogrel and the aspirin actually had a lower risk of the major ischemic event, but it's higher risk of a major hemorrhage actually at the 90 days of the trial. For example, the clopidogrel, for those who have received clopidogrel and also aspirin, the major hemorrhage is actually up to 0.9% as compared with a second group. Okay, so this is all for the clopidogrel and also aspirin. But then we have ticagrelor aspirin clinical trial as well. This is what we call that as a TELIS trial. This trial had been published in July 2020. This is a double-blind trial involving patients who had a mild to moderate stroke, non-cardioembolic ischemic stroke, who were not undergoing thrombolysis or thrombectomy. Actually, they will receive 30 days regimen of either ticagrelor 100 milligram loading dose followed by 90 milligram twice per day, plus aspirin 300 to 325 milligram on the first day, followed by 75 to 100 milligram daily, or matching placebo plus the aspirin. Shall I stop for the prayers first?
Yes, that's fine.
Continue. Okay, for the TELIS trial, it had been published in July 2020. This is a double-blind trial involving patients who had a mild to moderate acute non-cardioembolic ischemic stroke who were not undergoing any thrombolysis or thrombectomy. So they will receive actually 30 days of the regimen of the ticagrelor 180 milligram loading dose, then followed by the 90 milligram BD, plus the aspirin 300 to 325 milligram on the first day, and followed by 75 to 100 milligram daily, or matching placebo plus aspirin. As the result mentioned here, the primary outcome for those in the ticagrelor aspirin group is actually much more lower compared to the aspirin who had been received aspirin group plus placebo only. However, the severe bleeding is actually more frequent for the ticagrelor and aspirin group as compared with aspirin plus placebo only, in which the percentage is actually up to 0.5% compared to the aspirin is just at 0.1%. Okay, this is for the ticagrelor, Brilinta, aspirin, and also aspirin plus placebo. Okay, how about ticagrelor versus clopidogrel plus clopidogrel versus clopidogrel and aspirin? I mean, how about the comparison between ticagrelor aspirin and also clopidogrel aspirin? This is the trial. The trial had been carried out actually this trial actually had been published in November 2021. In which actually the outcome for those received ticagrelor and also aspirin is actually much more, the risk of the ischemic, the recurrent stroke is actually much more lower for those received ticagrelor and also aspirin as compared to the clopidogrel and aspirin. But then for the harm, I mean, for the overall bleeding is actually higher for those received ticagrelor aspirin as compared to the clopidogrel aspirin. But then in our setting, the recommended dual antiplatelet for the mild stroke or high risk TIA is still clopidogrel and aspirin. It's because of the cost, and essentially the ticagrelor is actually quite because of the major bleeding or overall bleeding is much more higher as compared to the clopidogrel and also aspirin. Okay, and then after all the trial that had been discussed here, maybe we can proceed with the same question as a pre-test question just now, so that I can know either I made you guys confused or actually you are quite understand more regarding treatment for the mild stroke and also high risk TIA.
Can you see the poll?
Yeah.
So we still have people not convinced.
We have 78 participants.
Do you have any other additional slides after this, Nazifa?
As for the ICATs, no, I think I didn't put in.
We will put in the discussion only lah.
Okay.
I think we open for question also after this.
Okay.
We stop at 1:30 seconds and I end the poll. It's interesting also to see that how people may be not able to answer.
All right.
Their device.
As compared to the pre-test just now, 68%. Just clopidogrel and aspirin, now 72%. And for those recommended duration for dual antiplatelet for the mild stroke and high risk TIA, most of them choose 21 days. Okay lah.
So the normal curve, yeah? So there's still
Yeah.
almost 8% didn't get the message.
Yeah.
So some still 90 days there. Okay. So stop sharing. Sorry, stop sharing. Let's download these results. Second one. Okay. So yeah, we open up to question. I think we have a question. Right. So Prof. Sharul is asking, these clinical trials were mainly on antiplatelet naive patients. So Nazifa, do you want to share from your readings?
Antiplatelet naive. Yes, actually, for the match chance Kelly's trial is actually for the antiplatelet naive patient actually. It's from my understanding, from my reading actually.
Yeah, majority of the patient, one of the earlier study, the exclusion criteria is a recurrent stroke. So their first episode stroke to prevent the recurrent stroke. So that's the way to go. In fact, I think if not mistaken, I think Prof. Lau also here. So if in the Socrates study, which is not presented here, aspirin itself, because of relevant to Prof. Sharul's question, is aspirin itself give a bit of protection. So then you need to basically put that into the accounts. So if you have a pre-existing antiplatelet, there's already a benefit. Yeah.
Yeah.
So now adding another antiplatelet give another extra benefit. So that's the key message for this selected patient. Okay. Maybe that's fine. Before we have more questions, what is actually the key message of your presentation today?
Okay, my key message is actually for those who had been diagnosed with a mild stroke, NIHSS less than 5, and also high risk TIA, which is ABCD 2 score more than 2. Actually, we can start with a dual antiplatelet therapy, clopidogrel and aspirin, up to 21 days.
Okay, so ABCD score 4 and more. 4 and more. Okay.
Yeah, 4 and more. Yeah, true.
Not 2. Okay.
4 and more. Yeah.
Okay.
High risk TIA, sorry. 4 and more.
So no questions. You can unmute yourself, or you can put in the chat if you're shy. Yeah, so Natalie going to a difficult question about those with aspirin allergies. What is your strategy? So basically don't give aspirin, they are allergic to the aspirin. So then you have the called clopidogrel, then ticagrelor as monotherapy. The thing is with the ticagrelor, lacking of data of a long duration maintenance. So that's the main issue at the moment. Okay, so I think with the Prof. Andrea and team, as PHCTM. So what is the correct answer? So at the moment, the thing is a bit difficult to put aspirin clopidogrel and aspirin ticagrelor within the same question. The question is not vetted just for the sake of understanding the key message today. I think the chance too that Nazifa shared just now is basically if you have a possibility of assessing the CYP2C19 non-functional allele, then the answer will be ticagrelor aspirin in the acute phase. But if you don't have the access, then maybe if we do question for MMAT, we cannot put aspirin ticagrelor together with aspirin clopidogrel as answer choices at the moment. Good morning. How about patients who are on anticoagulant? Is there any changes in the medication? You want to try first, Nazifa?
Patient already on anticoagulant. You mean on dual anticoagulant and then got recurrent stroke, is it?
So basically, anticoagulant is one of it, whether Clexane or Doax or warfarin. And now,
anticoagulant.
in your particular case, what happened to them? In this group, high risk TIA and also mild stroke, mild moderate stroke.
But then for the stroke, it's actually the trial towards the antiplatelet rather than anticoagulant. The anticoagulant trial is actually, they did a trial on the heparin and also aspirin, but I couldn't remember the names of that trial. It's actually for the anticoagulant does not play any role towards my stroke and to prevent the recurrence of the stroke, and also so the question is there any changes with the medication?
So in short, in your clinical, in the clinical trial that you shared recently, those that on anticoagulant are not tested in this group, right? So, but I think you were trying to mention to Victor, Dr. Victor is asking about and the role of anticoagulant. Maybe if we start with the IST1, heparin was studied against antiplatelet. Heparin shows a trend towards benefit. However, really increase the risk of bleeding by 9-fold. So that's the reason why anticoagulant is not the way to go for such in general case of stroke, unless they are at least clearly in our current evidence is non-valvular AF. Yeah. So in this subgroup now, high risk TIA and mild stroke, so the anticoagulant combination was not tested. So if your question is about the patient is already on anticoagulant, so then is there any changes in the medication? Which is not really the key message for today. But yeah, I answer because it's not fair for Nazifa. So we do see a trend where patient with non-valvular AF, especially when they have ICATs, intracranial arterial disease, they will have antiplatelet on top. The recent study shows that the recent cohort studies, when they follow up, this kind of patient will have more recurrent stroke and more bleeding event, which is no-brainer, right? So you see anticoagulant alone increased risk of bleeding. Now you then add on antiplatelet, increased risk of bleeding a bit more. However, I'm not too sure in terms of duration, whether they studied it almost the same like what you have seen presented by Nazifa just now. So maybe the future is a proper randomized control trial. If you have anticoagulant on board, a single antiplatelet, maybe in with underlying ICATs. This is in particular for stroke indication. Obviously, if there is IHD, that is something established. You need to know about it, and I think that's something easy for us to create an MAT question. So going back to the stroke, that may be the future clinical trial. If not, testing the new anticoagulant. There's incoming new anticoagulant. Hopefully that answer the question.
Ashraf,
I think yeah, you unmute. So,
okay, Ashraf, I hope you can see me. Ashraf, I just want to ask, in real world, yeah, managing patients, when you talk about this anticoagulant per se, we're looking at benefit, the potential side effect, but in reality, all the benefit outcome, is it independent of other risk factors control? Like most of our patients are diabetic, they're hypertensive, you know. Some patient came in with stroke, but A1C was 10, you know, I mean, not well controlled. Is it applied to this kind of patient? Because to me, I always believe in research, the way that they follow up, the way they get selections, they are looking for something, those ideal one. But in real world, we are not getting the ideal one. We might have a patient with stroke, but A1C still haru-biru, you know, and some other risk factors are not well controlled. Is it applied to them in real world?
So yeah, Professor Sundar, thank you for the question. Firial, I nampak Firial kat sini. Nazifa. Tiba-tiba Firial kena jawab soalannya. Nazifa, do you want to try or it's a bit difficult for you? Okay.
I have no answer for that.
What do you notice from the demographic when you look into the study?
The study, the inclusion criteria is actually quite strict now for the study actually. They will take, I mean, from the sample group, everything is actually for those who has new stroke, in which they are not mentioned, they are diabetic or not. So I have no idea how to.
Dah panic lah tu. So okay, so basically hypertension, diabetes, everything is there. But as highlighted by Professor Sinda, yeah, we don't know about the other sub-analysis of it, whether they may publish later on. But we know that if, for example, they have underlying diabetes uncontrolled, for example, so the likelihood of the platelet aggregation or platelet activity will be higher. And irrespective of which strategy of antiplatelet alone is not the strategy, it's actually the whole optimal medical therapy paradigm. If you have uncontrolled diabetes, we know that even aspirin clopidogrel will fail. Yeah, so I'm not too sure. Maybe we need to ask the cardiologist. Aspirin ticagrelor will be much more superior. This is with the knowledge now on top of almost 40% of Chinese population at least, and we know majority of us are Indo-China in origin maybe, and genetic wise, we are most likely also resistant to clopidogrel. So that is one thing. So the called information of a randomized control trial is very rigid. Selection criteria, at least 10% better outcome compared to real world. Yeah, so that should be in, part of our called a bit of pinch of salt there. So you cannot just translate everything. So I will usually say call sorry a bit to the cardiologist. We don't usually just dual antiplatelet everyone. For example, we know that end-stage renal disease patient, yeah, so they are a bit more risky in terms of bleeder. And stroke is very heterogeneous. We see the hemoglobin of 8 gram per deciliter is high. Maybe this is hypoperfusion stroke. So we need to look at the pathophysiology of the etiology of the stroke. So rather than just pukul rata, everyone should be the APT. In stroke is not the same. So if you are not too sure, which is not within the criteria being mentioned just now, advanced CKD, end stage, yeah, uncontrolled diabetes is not really a contraindication, but we know in terms of pathophysiology is a bit different. So those are the things that maybe from case to case basis, the stroke consults that still can be done.
Yep. Thank you, Ashraf. You did mention on the specialized group of patients. I think one of the special group of patients definitely those CKD patients and end stage. And majority in clinical trial, this group of patients being excluded for trial, you know. So to be honest, I don't know whether this is really translate in such a high risk, specialized group of patients, you know. And furthermore, we do understand that many patients with CKD, more advanced they started to develop platelet dysfunction to start with. Even our study, our local data showing about 47% have platelet dysfunction the moment eGFR less than 45. So putting double antiplatelet, yep, there's, in proper clinical trial structure, you know, we do know the benefit. But when we go back to real world, I think in real practice, if we are not sure, we get consult the expert Ashraf with us. And then rather than pukul sama rata and end up in dialysis, they end up is bleeding, you know, they receive heparin during dialysis. There are so many other things that might contribute. Yep, we don't understand. I don't want our master student come like textbookers, but fail to comprehend in reality. That's very important. Yeah, fail to comprehend the real life situation that we have to really think. The moment we're not sure, get us the consultant Ashraf, you know, sometimes I'm very simple too. I just give a call. I'm just not sure, even though I thought should be double, but eventually end up with single because we have different ways of assessment, risk assessment. All right, consider CKD patient. They are very specialized group. Nothing for them in reality. No proper research included them. And stage patient, another specialized group. Always consider what is the best for that particular patient. Thank you very much, Ashraf.
Thank you, Professor. So Nur Hayati asking about if patient on aspirin previously, would you switch to other antiplatelet after 21 days and provide if it's a mild stroke? So within the criteria, so we specifically just choose for today the criteria for the mild stroke and high risk TIA. So Nazifa, your answer for this is?
Means that this patient had recurrent stroke, is it, after on aspirin?
Yeah.
So that you should give clopidogrel and aspirin, in which a clopidogrel for 21 days and lifelong aspirin after that.
So you've changed back to aspirin. Patient originally on aspirin.
So means that this is aspirin failure lah.
Yeah, so basically, as you define as aspirin failure, then obviously this is the usual case also. Then we change back to the we change the aspirin to clopidogrel. Yeah. All right, that's the answer. But again, in the previous study, because of you want a patient who will gain the most benefit in the clinical trial, so a previous stroke is not included in the study, or a recent stroke that thrombolized and thrombectomy. They are a bit different risks, and that's maybe different benefit. So two good outcome after thrombectomy, then or thrombolysis, that may change the outcome of the patient as compared to those that didn't receive thrombolysis and thrombectomy. That was the reason for exclusion criteria. So kita tak nak very non-informative, very mild non-informative, very severe stroke non-informative to the clinical trial. So you cannot measure the final outcome. So that's the reason why they are excluded. So in reality, we then now know a recurrent stroke, we can put the patient on dual antiplatelet if they are within this criteria, 21 days. We will discuss, stay tuned for the next one when we choose to 90 days or more. Okay. So the answer is clopidogrel for that. That's maintenance.
Just to add on to that, in some countries, clopidogrel monotherapy is considered superior to slightly better than aspirin anyway. So that is actually the standard. Of course, we know that the study CACRI, all those they are predominantly in Western population, and in Asian population about 15 to up to 40% may have statistic 2C19 problem, and maybe the clopidogrel don't work as well, which is probably why we mainly give aspirin here instead of clopidogrel. But I don't think it's wrong to give clopidogrel long term. Might be slightly better.
Yeah, I totally agree with Prof. Lau. Yeah, if, for example, cost is not issue from our side, they're already on the DAPT. If they ask, and yeah, obviously, yeah, giving clopidogrel is a long-term maintenance, right?
Yeah,
it's not a wrong way to go, but yeah, obviously then the director or head of department then chase us why in terms of cost over here. But benefit, totally agree with Prof. Lau, there's more with clopidogrel, although as a single monotherapy.
Is there any question? No, I think we should end the presentation.
Thank you, Nazifa.
Okay.
So basically, if any questions, just PM Nazifa, then Nazifa will PM me. If we cannot answer the question, then we ask all the other consultants, Prof. Lau, Prof. Nafisa. Okay, and at least I think the one that Nazifa shared today is quite clear in terms of the indication, and hopefully we can see a change of practice for this subgroup first. The next subgroup that going to 90 days, I just give a bit of hint. Usually one of the key message you see the first case is we must have a CT scan plane at least with a vascular imaging of the brain in majority of our patients, especially they are salvageable. They are called clinical frailty index. We learn in COVID care, right? So it's not too high. So there is still salvageable function. Janganlah refer MRS 5, obviously MRS 6 you don't refer lah kan. So MRS 5, that clearly the life expectancy at 1 year, there's no benefit. Yeah. So those are the things that we should know, as what Prof. Rosinda mentioned. We are clinician. Yeah, we want to train you to be a good clinician, not just to follow the books or textbook, or you claim you follow any guideline. You are clinician. Use a bit of your brain every time you prescribe. Know the efficacy and know the safety of the medication. Okay. If no other question, I can see over here. We end up our CME today. Thank you, everyone. Thank you, Nazifa.
Okay,
thank you. Consultants for the question and also opinion. Thank you.